All set to start.
Hello everyone. Welcome to ERF's 27th conference on sustainable development goals and external shocks in the MENA region. We are today doing the health team. We are recording the session, and it is also live in YouTube. So you can also later go back and again watch the presentations and the discussions. As I said, today we are having the help team. We have 4 papers. During the presentations, if you have questions, at the bottom panel we have Q&A section. From there you can send your questions to the presenters or the discussants. Or if you want to have the floor for the discussion at the end of the presentations and discussions, we will have time for the questions and answers as well. At that time, you can also ask your questions yourself. The first paper today is Dynamic Governance of the First Wave of COVID-19 in Tunisia. It's an interoperability analysis by Amira, right? I'm sorry if I lost the tag here. Sorry. By Huda Bubaker, Khalid Nasri, and Najef Dawadi. And let me tell the second paper as well, so that I don't interrupt. It is Policy Responses, Social Norms, Behavior Change in the Time of COVID-19. And it is by Amira Eslal and Eman Mustafa. So if the first paper is ready, we can give the floor to them for the dynamic governance of first wave of COVID-19 in Tunisia and interoperability analysis.
Hi, hello everybody. I'm just trying to, yeah. No, that's right. But just I'm trying to put it as yeah. In fact, yes, in that way, yeah. Okay, so do you see my screen?
Yes, perfect.
Yes, yeah, it's perfect. Mm-hmm.
Thanks a lot, Bilgi. Good afternoon, everyone. And thank you for being here. I would like to thank the ERF for this opportunity to present this joint paper on the dynamic governance of the first wave of COVID-19 in Tunisia and interoperability analysis. So we know that since 2019, all the world is gripped by the new severe acute respiratory syndrome, which was declared as a pandemic by the WHO in March 11. And some literature stressed the wave characteristics of this pandemic as plumber and Neumayer. And this, in fact, underpin our choice of the approach of dynamic governance to analyze this first wave pandemic in Tunisia. So understanding how countries were able to fit or to fight, this first wave in certain and dynamic environment will help the policymakers with the argument that they can use to face the following waves. In Tunisia, as all governments all over the world, they starts by the implementation of early preventive measures to prevent the virus to enter the country. And this first wave on Tunisia, it happened from March 2 to June 13 to 2020. And there is a second step when once the virus is here, the government, they don't have the choice. they should change or adjust their strategies in order to by adding new strategies or by rising the degree of strictness by which some measures are adopted in order to reduce the burden on the health system or in the economy in general. This is, in this graph, we are presenting the different steps or the different periods that we identified in this first wave of COVID in Tunisia. So we have the first before the lockdown period, which is divided into two periods, from March 4 to March 12, then from March 13 to March 21. So in the first period before the lockdown, we have two periods. Then we have the period of the lockdown. Then we move to extension two times this lockdown in period 4 and 5. After that, we move to the targeted lockdown and then to the last period, 7th period, which is the deconfinement. The ultimate objective of this paper is to quantify the interoperability measure taken by the Tunisian government to manage this first wave. Especially, we will try to calculate the index of strictness or stringency, which records the strictness of government policies inside each period. In a second step, we will estimate the degree of interoperability between two measures for two successive periods, and after that, we'll determine the whole matrix of interoperability. We retrieved our data from the CGRT, Oxford COVID-19 Government Response Tracker, and the validity of this data, it was cross-checked by data from CoronaNet, which is based on statistics provided by the National Observatory of New and Emerging Disease, the ONME, in Tunisia. Our data cover three different categories. The first one is about containment and closure policies. The second one about economic policies, and the last one is about health system policies. So our methodology is based on the interoperability concept, which has been adapted from the defense to the health system in this paper, and is defined as the ability of measures, public policies, or any programs that have interests or objectives to be achieved to operate together. So the implementation of the operational system, there are some steps which are required. The first one is the system identification, as we've seen in the figure number 2, that we identified our system as which comprised 7 periods, P1 to P7, that cover all the first wave period in Tunisia. In the second step, we instantiate each measure for all the measures taken, which are 13 measures here for for each period, and those measures will map the system to some measure states or states of these measures undertaken for each period. That's why in the last step we define the different states. So we know that the government are and following the dynamic governance approach, where the government has to think ahead and create feedbacks and think across the defined strategies. That, for example, if a measure is absent during a particular period or it was relaxed, each state is coded as with the value 0. And if the measure is just recommended, we code its state as equal to 1. But if it became mandatory, or it's mandatory, so each state it takes the value 2. Then we have two quantities to calculate. The first one is the index of stringency, meaning the strictness by which the government is applying these measures between the different measures for each period. And we calculate the interoperability index or a measure for the measures between periods. So this is an example of how to code and how to identify the system. So the identification given by the subperiod that we find in the third column comprised by P1 to P7, and the different measures that we took here, just an example. Okay, it's about the first period of the before lockdown period. And this is how to code the different states for each period. Our result, the first one here, we have the stringency index, and we said that it will record the strictness by which the government will apply its adopted measures. And you see that we start with the index for the first period as having the lowest level, and this is logical because it's the first time that Tunisia is facing such pandemic. So the government don't know how to deal with it, what are the measures that should be taken. So that's why we have this low level. And after that, with time, and as it's a dynamic analysis of this pandemic, we observe that the Stringency Index is increasing, and it reached its highest level of 93.75% by the period of the lockdown and two extension P4 and P5. And after that, with the targeted lockdown and the confinement, we see that the level is dropped for the strictness by which the government deals with this pandemic. When we analyze the interoperability between two periods, which is given here by M12, so we obtain these values for the different periods. So the interoperability measure for the first period 1 and 2, it's equal to 0.190. This low interrogability between period 1 and 2, it's mainly due to adding new measures in period 2 and also relaxing the strictness, applying some other measures. And in fact, it reflects the weak reaction of an average of the Tunisian government to the evolution of the epidemiological situation. However, this reaction is a little bit improved in the period 3 by adding new other measures. And if we come back here, we have that the index of stringency, it's became equal to 50%. Then when we observe that for the period 4 and 3, there is, in fact, we didn't add new measures for the two extensions of the lockdown. However, the stringency index is at its highest level of 93.75%, and that's why here we are observing that interoperability index is also reaching the highest level of 0.846. After that, when we move to the targeted lockdown, and by relaxing, especially the measure of staying at home requirement is no more mandatory, and we move to a partial opening workplaces, that the stringency index also is dropped, and that's why we're obtaining here an interoperability index equal to 0.628. By reaching the last period of the deconfinement, which is characterized by removing a major part of the measures, we recording the lowest level of interoperability of 0.273. So here we present the final interoperability matrix, and there is evidence that the measures taken in the first period P1 have direct impact on the second period P2, but also it has an indirect impact on the successive subperiods P3, 4. Because the formulation, the transformation, and the created information in P1 will eventually pass it to the other subperiods, even if it's not just a successive period. So to conclude, our approach of the dynamic governance that we used in this analysis of the first wave COVID in Tunisia help us to identify 7 periods, and such classification allowed us to break down this period into 7 periods. Then we have modeled each period by using 3 codes, a codal situation of the measure, and reflect on the dynamic of the measure in terms of their stringency and inclusiveness. On March 23, the period of the lockdown, the level of stringency government responses to this first wave reached its maximum level of 93.75%. With such a maximum level, also the government dealt with the 2 extensions of the lockdown. By the end, that there is a clear evidence that the pandemic crisis cannot be managed or defeated with one single measure, even if we have a higher level of stringency, but it was managed by several policy responses which interact together over time. And thank you for your attention.
Thank you very much, Huda. This was great. So, as I said in the beginning, maybe for the newcomers, we will take the questions at the end. So now we will listen to the second paper. So you can send your questions from the Q&A section or you can have the floor at the end at the discussion. Now we will listen the second one, policy responses, social norms, behavior change in the time of COVID-19. The paper is by Amira Eslal and Eman Mustafa. Eman Mustafa will be presenting the paper.
Yes, thank you, Belgi, and thank you, Dr. Shireen. Thank you for the ERF for this opportunity. Our paper today is about policy responses, social norms, and behavior change in the time of COVID. As we can see, and in the start of the first wave of the pandemic in March 2020, and in the absence of COVID-19 treatment and prevention, social distancing and other precautionary policies and measures were enacted by all governments all around the world, as we can see from the figures, to mitigate and contain the pandemic. We can see that almost all countries in the world enacted such policies, but although all countries, or almost all countries in the MENA region and in all over the world started acting these policies in the same time, actually, basically it's March 11, 2020. The substantial variability in the individual adoption of precautionary behaviors warrants understanding of factors that motivate or inhibit adoption of these policies. So we found that cognitive, social, and affective factors, especially those related to disease risk perception, social norms, and risk perception, are central to the prediction of health behavior of individuals all around the world, and specifically in the MENA region. And addressing those factors can promote health behavior change and can help governments and policymakers to make such more effective policies. So our objectives in this paper, we answering actually two main questions. The first one is about the effect of government containment, closure, and economic policies versus that of the actual disease risk, public perception of that risk on behavior change. And the second one is how do the social norms for risk-taking, patience, and trust determine the heterogeneous effect of government policy responses to COVID on mobility behavior change. Our empirical approach is actually following Booldridge. We propose a diff fixed effects model to estimate the effects of multiple determinants of human mobility behavior responses to the pandemic. And we compare the treatment group, which is the daily change in visit to various locations in countries adopted COVID-19 related policies, with the control group, which those who didn't. For each country, we estimate the following equation. We have the dependent variable is a change in the frequency of visits to various categories of places. And we have P, our main variable is the matrix of related containment, closure, and economic policies, and actual risk, as well as public perception of the COVID-19 risk. And we control for weather effects and seasonal weekend effects. We use different strains of data sets. Basically, we use Google Community Mobility Report to address human mobility, and Oxford Government Response Tracker for policy responses. And as you can see, different sources of data. Our results show that for the MENA region, a level of strictness and of containment and closure policies is associated actually with significant reduction in the frequency of visits to places classified as retail, retail and recreation, transit, stations, and workplaces. And moreover, inconsistent with the results of the pool sample, our pool sample in the paper is 132 countries all over the world. So inconsistent with the results with the pool sample, we find that economic support index has no effect on mobility behavior, but for residential places, and it's weak significant. As for the risk perception proxied by disease uncontrollability, and wakefulness, they have no effect on mobility behavior, but for transit station and residential places. The MENA populations also appear to be less responsible to actual disease risk. When we come to addressing and examining heterogeneity in behavior change, we categorize it by different groups. The first one is risk preference. And we compare mobility behavior change among risk-neutral population in MENA to risk-neutral populations elsewhere in the 132 countries. All over the world. So our estimates show that the containment and closure policies imposing restriction on gathering help achieve positive behavior change among risk-neutral populations in the MENA, as you can see here. And contrary to the other regions, stay-at-home requirements appear to have induced negative behavior change in the MENA. We also observe that risk perception and communications through public information campaigns appear to have stronger effect among risk-neutral population in regions other than MENA. The second group is the time preference. So we compare mobility behavior change among inpatient populations and moderately patient populations in MENA. Inconsistent with the results of the pool sample, individuals who are more patient in MENA are not more likely to lower their mobility independent of government containment and closure policies. So if workplaces closing is not stringent, it facilitates actually here negative behavior change in the region. Even more among moderately patient populations in the MENA, we still observe significant but lower actually increases in the mobility to places classified as retail and recreation and parks as well. Our last category is the trust in others, especially politicians. So we have here, we report joint estimates of 3 groups of countries: low trust in politicians, medium trust, and high trust in the MENA. So we find that similar to other world regions, the effectiveness of risk communication in promoting behavior change depend on the level of trust in others, specifically politicians, and only among populations with high trust level in the MENA region, we observe significant reduction in the mobility to places classified as retail, parks, transit, workplaces, in association with coordinated public information campaigns, as we see here. From that, we conclude that MENA populations are less responsive, actually, less responsive to COVID-19, as well as the actual disease risk compared to other world regions. And risk perception also appear to play a less significant role in inducing behavior change in the region. And similar to the other world region, in MENA and all over the world, the effectiveness of risk communication in promoting behavior change depends on the level of trust in others, specifically politicians. And we can draw some policy implications from that risk management strategies aiming at the rapid adjustment of individual behavior will continue to be one of the frontline policy responses available as a tool to governments and policymakers in the face of COVID-19 and any coming viral threats. I hope we don't have any other COVIDs in the coming days. Besides confinement and social distancing intervention, policymakers should navigate policy options that seek to engage and change public risk perception. Where a relevant policy option is risk communication, or in a broader way is information dissemination and media reporting. As we saw from the results, it's effective not in MENA, but also all over the world. And to augment the effectiveness of public policy responses during public health crises like COVID, governments should tailor them to prevailing social norms for risk-taking, patience, and trust, especially trust in politicians and trust in government, as we found it significant all over the way, all over the world. Thank you so much, and we're happy to receive your feedback and questions.
Thank you very much, Emma. Let me share my slides now. So I want to thank two authors of both of the papers. They are both are very well thought and well done, and they are both on COVID-19. So it is still very much alive for all of us. So it was very interesting to read and listen both two papers. Now I like to give my comments first with Huda, Khalid and Nasef's paper, and then I'll continue with the second one. So first of all, I'm not familiar with this topic, this interoperability analysis. And as you said, it's actually used in the defense sector, right? So please forgive me if I missed something or if I interpret the implications of your results wrong, or if I overstep the aim of your study. So let me first briefly summarize the paper to us all again. So this paper aims to propose an interoperability index of the measures taken and adjusted by the Tunisian government during the first wave of COVID-19 epidemic. Interoperability is defined as the ability of measures, public policies, or programs having common interests and objectives to be achieved and to be operated at the same time. Authors' findings show that the pandemic management strategy in Tunisia during the first wave of COVID-19 has been adjusted by adding new pandemic policies and changing the stringency levels over time. And they also show that the measures taken early in the sub-period interact directly with the next successive sub-period in the decision process, but they interact indirectly with other successive sub-periods. So basically, authors provided us with this interoperability index and stringency index during the pandemic management. So as I said, I wasn't familiar with this topic before this paper. So when I read about this index, so the thing that's not clear to me is the policy implication of this index. So So when I look at how it is defined, how it is calculated, to me, it is like as the disease spreads, as the management of the disease require new measures. Government needs to add new measures, but by adding these new measures, interoperability index between sub periods just mechanically decreases, because as you add new measures, the like the correlation or the interoperability between the two periods are decreasing. But the thing I don't get it, does it say anything about the effectiveness or efficiency of these policies? So does this interoperability index alone tell us anything about the how government is doing at the epidemic management? So is it what I mean is, so you need to add new measures and it just mechanically decreases the interoperability index, but it doesn't mean that it is a negative thing, right? So I'm not clear about the policy implication of this index. And similarly, at the stringency index, so again, as the disease spreads, countries all over the world, they had to take stricter measures. So at the beginning, some countries acted promptly, some prefer to apply the wait and see policy. But as all of us see things are getting worse, stricter measures were taken everywhere. So again, I am not sure what this stringency index alone tells us. So for either of us, either of the indices, stringency index or interoperability index, do they necessarily provide any input for health policy or public policy, how we should use them or how we should interpret them? I'm not clear at that point. The thing that comes to my mind, whether we can relate these indices to disease spread, case numbers, disease control. So can we expand, maybe, as I said, maybe it is I'm overstepping the aim of the study, but can we expand this study in Tunisia or by including other countries to provide policymakers with some input, like this stringency level gives us this much control, or this stringency level is not efficient, something like that. So or if we can expand this to other countries, can we compare number of cases, fatalities in two countries with different stringency index? So can we so at the beginning, some countries, some experts advocated herd immunity and some advocated strict lockdowns. So can we relate these to those discussions? So can we provide some insights about different policies resulting in different outcomes about the disease and the disease spread? And also, can we or can you provide evidence on the efficiency of different fiscal, monetary, or social measures on the number of cases or the fatalities. So my point is, so as out of academic curiosity, we examine a lot of topics, but I think especially at the COVID-19 case, I am expecting a bit more policy relevance. That's why I was looking at the paper in such with such an expectation. So that's all I want to say on this one. I will continue with the second paper just in a second. So I'm continuing with the second one. Again, thank you, Amira and Eman, for the presentation and for the paper. Policy responses, social norms, behavioral change in the time of COVID-19. Let me again briefly summarize the paper. This paper is using a difference in differences and fixed effect framework to estimate the effects of government containment, closure, and economic policy responses to COVID-19 on changes in human mobility behavior. In a cross-country study, they have data from 132 countries. Authors account for the actual disease risk and public perception of that risk. They study how social norms, including risk-taking, patience, trust, explain the heterogeneous effects of policy responses on behavior change. Authors show that the stringency of containment and closure policies decreases human mobility, while economic policies lead to a less significant decline. Stronger adjustment in the public mobility behavior originates from their risk perception rather than being policy-induced. Authors also show that risk-averse populations and those who exhibit more patience correct and lower their mobility independent of the public policies implemented. Economic support triggers negative behavioral change in time preference setting, where increased mobility is reported, contrary to the settings where populations are more patient. And lastly, risk communication elicits positive behavioral change among risk-averse and impatient populations who reduce their mobility. The effect varies by trust in others and especially trust in politicians. Here my first point is that authors argue that time varying unobserved country heterogeneity is not a concern in their context because their analysis covers a period of less than 6 months. Therefore, they argue that difference in differences provides unbiased estimates. However, this might not be the case. So we know that across the countries, different economic support policies have been implemented during the epidemic, and these different economic support policies might lead to different trends in terms of income and job losses or social protection. And this might make the control and treatment groups less comparable. And then the identification, the assumption that defensive relies on, that the control group and treatment groups would have the similar change in the absence of the treatment, might not be holding. So in that case, the estimates would be biased. For this, I might offer authors to relax the parallel trend assumption. Differences literature is changing and developing every day. So with the new studies, we see that now they are among other things, now they are relaxing this parallel trend assumption. So you might think about adding country-specific time, month, or day, whatever the data you have, dummies, to let them to follow different trends. I think that would help to eliminate this concern about the different countries having different policies leading to different trends in your outcome variables. My second point is about access to information and about the transparency of the epidemic spread and epidemic governance. So access to information might not be heterogeneous across countries. So in a less transparent, most of the time less developed setting, citizens might underestimate the actual risk, and they don't decrease their mobility as much as it happens in more developed countries. Because most of the time in developed countries, we believe in the data, we believe the information is transparent, and the information that citizens get is the whole information. But in less developed regions, most of the time, unfortunately, we don't rely on the data, we don't believe in the data, and we always, in the back of our minds, we always think that things are actually worse, might be worse than the things that is reported. So in such a setting, in a less transparent area, if this is the case in the less developed regions, citizens might underestimate the actual risk, and so they don't decrease their mobility. And you're finding that in MENA populations, the citizens are less responsive to the actual risk might be stemming from this fact. If compared to the other regions of the world, if in many regions the reported cases, reported information is less transparent, meaning not indicating the whole situation of the epidemic, citizens might underestimate the COVID risk, and they might be less responsive to the disease and disease spread. So that's one of the points I wanted to make. Another thing, you rely on the assumption that exclusion of the population without smartphones don't impose any problem. So you rely on the mobility data and mobility data is coming from smartphones. So whether we restrict the mobility, whether we decrease the mobility, the citizens do that, you get that information from the smartphone data. But not all the population, not everyone has smartphones. So so this is the this is from state of mobile internet connectivity. There is a similar graph in World Bank data as well. So this is based on El Hamidi 2020 study. So it says that the price level of an entry level, just the basic smartphone, represents 96 points of GDP per capita of the poorest 20% of the MENA population. So smartphone penetration rates are still below 50% of the mobile users. So the poorest, the 50% of the poorest 50% of the poorest 20% of MENA region, that population doesn't have smartphones, and since they don't have smartphones, they are not included in your data. And I think it poses, it might pose a problem, because according to these figures, low-income people are more likely to be without any smartphones. But at the same time, those people, those disadvantaged population, are also less likely to be adjusting their mobility, because they are already doing very poor in terms of income and other socio-economic outcomes. So they don't have much room to adjust their mobility. They have to keep ongoing working, and whether it is formal or informal, they are still out there. So and at the same time, those are the people that are more likely to be negatively affected from the pandemic. So you don't have those people in your data, and I think that might potentially give you some biased results. So I'm not sure if there is a way to fix that. So I just want to point out this part. You might want to think about that, because those are the people who are most affected from the pandemic. They won't be able to, even if they want to, they won't be able to adjust their mobility, but at the same time, they are not in your data. So I think it might be contaminating your results. So I want to make that point too. So thank you again, both of you, both papers and all authors. So before going on to the next two papers, we have sorry, let me close the, we have a floor for discussion of these two papers. We have 10 minutes or so. If you have questions, you can ask. And also, please, Huda and Emma, you can answer the points you want to make, whether there are points you want to make about my comments. Please,
okay.
have the floor.
Thank you, Bilgi, for the summary that you made for our paper. Yes, everything was right, and we'll summarize it. In fact, I want to stress two things, that the interoperability is, as I said, it was adopted from defense to health, and it will measure or indicate for the governance the operational aspect between the different entities, because in the defense, the different entities in the government, they are considered as a whole system. And where we observe that if, for example, the first entity, it will take any measure, it will affect the second one, then there will be such a feedback. This measure can be removed, can be extended, can become mandatory, and so on. And this system also can affect the third entity, and so on. Okay, so the second thing is that, as the literature said, this pandemic, it has the wave characteristics, means that it will happen each time as such waves. And I think that as it's the first time that this measure, it has been adapted from the defense to the economic or to this health problem, that it can be considered as an indication or as a measure that the government can use to determine the effectiveness and how coherent is the different strategies proposed or suggested by the different ministry to manage this health problem. So it can be also considered as a proactive indicator, because if we consider the wave characteristics, the government, based on this interoperability measure, it can make such a simulation of the different scenarios and tell, for example, if if the second wave will came, and maybe given that we had a lower stringency index and a lower interoperability between the two, for example, P1 and P2, if we will undertake the same measures, maybe we will fall in the same mistake. So it's a proactive measure. And we know that the WHO has classified Tunisia as one of the countries that well managed this pandemic for the first wave, but not for the second one and third one. And yes, you said that if it's possible to extend the use of interoperability, yeah, for sure. But just because the paper proposal, it has been during just the first period of this pandemic, we didn't extend it to the second wave. But yes, it's one of the exercises that I invite also my co-author to do it. And doing so, we can compare, and we are sure that we'll obtain low values of stringency index and of interoperability measures, because, you know, Tunisia didn't manage well the second and third wave. To extend this measure to another countries, yes, it's possible. Why not? And doing so, maybe we can compare MENA countries and other European countries, for example, and try to draw some conclusion for the policy implication of such measure. I mean that here, for example, we invite the Tunisian government to gather the committee of ministry committee and also the scientific committee. Don't forget that the health ministry, it played a major role for all governments, because it's the first one, according to the statistic they have, to announce which measure should be adopted for each period. Okay, so we invite them to gather all this committee and to maybe try or test our measure of interoperability, to have this proactive and to know what to do if there will be a fourth wave. I hope it's not happen. What else? Could you please come back to the question, because I didn't have time to take note of all the questions.
I think you covered
the major part.
Yeah, so extending in Tunisia and to other countries, basically. And
yeah, maybe we'll make a comparison between the MENA countries and Maghrebian countries. It will be a good exercise, and maybe between oil importing and oil exporting, and here by adding some other different input, and why not to look what's happening in the oil activity and does it affect or not. Yes, it's a very important exercise. It's a new vein that we should do it. Yeah, can you relate this and this is to disease spread? Yeah, for sure. Because we present in our paper the evolution of the pandemic, and the graphs present the number of cumulative confirmed cases. And yeah, for sure that it's the first indicator for the Ministry of Health to ask the adoption of some measures to be mandatory. And that's why we have the index of stringency reaching 93.75% for the lockdown and the 2 extended periods. Yeah, for sure, this stringency it indicates that each time that this index is increasing, this means that we have a lot of number of deaths, and also a cumulative number of confirmed cases that is increasing for the period 1, 2, 3, and 4. Yes, I think that it's what I was telling you, that such a measure, I think, as being a proactive measure, and we will do the exercise for second and the third wave. We'll inform you about what we find as a result. I want to thank you also about all these questions. Thank you very much.
Thank you. Iman, if you want to make points, so without taking much time of the other 2 papers, you can have floor for like 5 minutes. Please.
And I think Amira is asking for the floor. She had her hand raised as well.
Yeah, actually, I will give Amira the floor to answer all the question in the in 5 minutes. Yeah.
I have to pay my due. So all right. Thank you very much, Belgi, for the very detailed comments, and they are very, very beneficial to us. And they are actually all valid. We cannot underestimate the importance of any of them, especially the third one. So so for the issue of the mobility data, it's not a problem, and we actually explicitly stated that in the paper. You are actually and this is actually the comment or the concern we have received from other reviewers as well while we were applying for from journals, because we have to have to accommodate this, we have to have a separate section in the conclusion on data limitations that this may bias our results as you are suggesting, and that we should be able to discuss the direction of the bias. Will it be biasing it upwards, downwards, and how this bias will differ based on the prevailing social norms. So your comment is very, very much valid and appreciated, and we would actually have I think we'll have to discuss it explicitly as a data limitation or a limitation of the whole study. We couldn't have we don't have access to any mobility data other than this and the Apple mobility data. So these are the 2 publicly available data sets. The Apple mobility data is very it's very poor in the MENA region compared to Europe, because actually the Android devices are the ones that are usually used here in the MENA region. So we had to rely on the Google mobility data, but we will accommodate your comment, and thank you very much. And if you will allow us, we can use even the statistics you have provided here. They will be very beneficial to us. So this is for the third. Yeah, thank you very much. And quickly, I will go to the first and the second comment. The first comment on the time varying unobserved country heterogeneity. This is actually also a very valid comment, and have to expand the discussion on the reliability of our results, because we were trying to do we understand that there can be heterogeneity, but given the small time horizon, we don't expect that there will be major changes in the economic status or in the social status of the population, especially the education data, educational attainment, the income levels. We may have waves, some people may go unemployed. I understand this, but we're trying to see if the income level of this population or that population or subpopulations, we don't expect them to change in like 3 or 4 months. So we try to add country and day specific fixed effects in the model to be able to account for this to the best we can. We can also like expand the event study we have done because we are trying to like establish the parallel trend assumption, allowing for leads and lags of the treatment. So maybe we can like expand this discussion and move it to the methodology section to try to like defend the methodology we are using and maybe like add other robustness checks. And also we like our main argument is that the dependent variable here is the mobility. So given like we don't like expect a direct effect from the economic like status or educational status on the mobility, other than the general trends in the population that, for example, if you are well educated, you would have access to information, you would be like have like good knowledge that you should be avoiding that, or that you should be like adopting this precautionary behavior, etc. And this actually brings us to your second point, the access to information and the differences across countries. And we try to accommodate this by including the actual risk versus the risk perception, because as you were saying, they will differ based on the access to information. The actual risk is the actual number of cases and the actual number of fatalities in the country, and the risk perception, as you were suggesting, will be basically relied on the access to information. If I have like access to information that these people are my neighbors are going through this pandemic, or that they are suffering, or etc., I'll be having my risk perception itself will be more realistic, and it will actually be closer and closer to the actual risk perception. And maybe we can accommodate this by expanding the part on the public information campaigns, because this is the way, or this is the indicator we are including, that should be like targeting the information that is made available to the population to be able to adjust the risk perception or the perception of the COVID. So maybe we can like use this as a kind of a proxy to the access to information, and to see or like estimate how coordinated public information campaigns can like be able to guide the behavior of population, especially those that don't have actually information, or they are not knowledgeable enough or not educated enough to be able to access this information themselves. I think it would be very beneficial to expand on this. And thank you very much for the detailed feedback and review of our paper. Thank you, much appreciated.
Thank you. Thank you again, Huda, Amira, Iman. So yeah, we almost did it on time. So I will give the floor to Marwa and also the next two papers. Please go ahead. Let me stop sharing.
Thank you, Belgi. Good afternoon, everyone. I am Marwan Khawaja from the United Nations Economic and Social Commission for Western Asia, and I'm based in Beirut. We have electricity cuts, so just a warning, if I disappear, I will be back in a minute or so. It's Beirut. So we have two very interesting papers. Belgi, do you want me to introduce the papers, or you want to do it?
Please go ahead if you have it.
Okay.
Okay.
So we have two very interesting papers. The first one is from Egypt. Both of them are based on natural experiments. The first one is by Ahmad Rashad and Misbah Sharaf, entitled "Does Maternal Education Curb Female Genital Mutilation? Evidence from a Natural Experiment in Egypt." And the second paper using a similar methodology by Hanifa Bilbar and Kausar Yousfi. The paper is entitled "High Rates of C-Section and Its Consequences for the Timing of Birth." I think we can start with the Egypt paper, just to introduce the speakers. Misbah Sharaf is professor in the Department of Economics at the University of Alberta, Canada. And the co-author, Dr. Ahmed Rashad, is a senior economist at Dubai Department of Economic Development in the government of Dubai in the United Arab Emirates. He has a PhD in economics from Germany, and previously he was he worked as a consultant at UNDP, ASQA, etc. So I don't know who's presenting the Egypt paper, Misbah or
Yes.
Ahmed.
Yeah, basically it's going to be me, Misbah Sharaf.
Please go ahead, Misbah. The floor is yours.
Okay, thank you. So let me share my screen. So is this good enough?
Yeah, excellent.
Okay, great. So hi everyone. I would like to thank the ERF for giving us the opportunity to present our paper, and I hope everybody and the ERF family are all safe during this tough period. So today I will be presenting our paper, Does Maternal Education Curb Female Genital Mutilation? Evidence from a Natural Experiment in Egypt, co-authored with Ahmed Shukri. So just to give you an informal background for our paper before I go into my presentation slides. So in this paper, we are trying to benefit from a natural experiment. There has been an educational policy reform happened in 1988, 1989. That reform reduced the number of primary schooling from 6 to 5 years, and that converted the Egyptian compulsory education system from a 9 to an 8 years education system. So we are going to benefit from that natural exogenous policy shock. We are going to benefit from that to estimate the causal impact of maternal education on one of the highly prevalent adverse health behavior, which is female genital mutilation. So I'm going to use FGM throughout that presentation to refer to female genital mutilation. So we're going to benefit from that natural experiment to, as I mentioned, to estimate the causal impact of maternal education on that outcome. So there is a huge medical evidence on the adverse effects of that behavior on the woman and their children, whether psychological or physical health effects. And as a recognition of the importance of ending this practice, the United Nations has included ending female genital mutilation, included it as one of the sustainable development goals. And unfortunately, Egypt has the world's highest number of circumcised women. About 92% of the Egyptian adult women had been circumcised. So here we are using Egypt as a case study, and we are using, as I mentioned, that exogenous policy shock to examine the impact of maternal education. So as I mentioned, starting from 1988 to 1989 school year, there has been a reduction in the compulsory years of schooling from 6 to 5. And all the students who were born after October 1977 were exposed to that policy reform. So now we have two groups of individuals, people who were born before that cutoff date and people who were born after that cutoff date. So we are gonna compare this cohort of students who were born before and after that policy shock. And as I mentioned, education has been widely considered a protective factor against many adverse health risk behaviors, including FGM. So here in this paper, we are going to study the impact of maternal education on three outcomes, three FGM outcomes: the actual practice, and the attitude of the mothers toward the practice, and their intention to perform the practice in the future. So here we are going to focus on three outcomes, and this is one of the contributions that we are making to the literature. So most of the previous studies, they only focused on the impact of education on the actual practice, but here we are covering a wider set of outcomes. So as I mentioned, the change in the compulsory schooling legislation provides a natural policy experiment, and this has been widely used in the literature to instrument education. For example, a couple of studies have used Turkey's education law that increased the compulsory schooling from 5 to 8 years within an instrumental variable approach to study the impact of maternal education on several health risk behaviors like denser and guns. The same education reform that we are using in the current study has been used in several earlier studies to examine the effect of maternal education on several health and labor market outcomes, and the findings were mixed regarding the impact of maternal education. And this is a sample of these studies that used the same experiment, like Ali and Sayed. They studied the impact on child mortality and nutrition status, and Ali and Gromo, the impact of maternal education on several fertility outcome. And we have Sayed and Maria, they examined the impact on educational attainment and labor market outcomes. So here the main contribution of our study is that, as I mentioned, we are going to cover a wider set of outcomes, not only the actual practice, but also the attitude and the intention to perform the FGM. And most of the existing literature in epidemiology and in public health, that examines the effect of education, they are mainly examining that effect in a non-causal fashion. And these studies largely ignore the indigeneity of maternal education, and their results are going to be biased because of that. And their results are going to be interpreted as correlation rather than as causal. But in the current study, we are trying to overcome some of these limitations in the earlier studies by using that natural experiment to get causal inference about the impact of maternal education on FGM. For the data, we are using data on a sample of over 16,000 ever married women aged between 15 to 49 from 2008 Egypt's DHS, Demographic and Health Survey. And we are using a fuzzy regression discontinuity framework to estimate the impact of maternal education on the three FGM outcomes. Here, the merit of the fuzzy regression discontinuity is that it allows us to control for the cohort effect by exploiting a narrow cohort variation in exposure to the different compulsory years of schooling. So here, that strategy is going to be relying on comparing two cohorts, those who were born before and those who were born after the cutoff date, which is October 1977. Our key finding was that, unfortunately, we found that maternal education has no statistical significant effect on the actual practice or the intention to perform the practice in the future. But we do find a statistically significant positive effect in terms of reducing the supportive attitude toward the practice. And this figure just to give a summary for what we found. So here we can observe that there has been a discontinuity in the first outcome, which is the support for the continuation and also for the intention. but there was no discontinuity in the actual practice of FGM. So here we one explanation for why maternal education is playing a limited role or a limited protective role in this regards is the poor quality of schooling in Egypt, as in many other developing countries or other middle income plus countries. And more importantly is the power of traditionalism versus education. So the habits and the traditions here in Egypt, especially in rural areas, they preserve and they push many families to implement the practice regardless of its adverse health effect. Recently, the Egyptian government, I believe from a couple of months ago, they started to amplify the legal penalty for implementing the practice. So maybe the person who performed the practice is going to be in prison for about 15 to 20 years. And if it caused death, it's going to be longer. They're going to spend longer penalty. So the government is trying to use the legal system to face that phenomena here in Egypt, given its high prevalence rate. But still, we believe that legal solutions alone will not be sufficient, and we need a multifaceted approach to face that phenomena. And we were hoping that education would be one of these instruments that we can rely on. But based on the results that we found in this study, we did find that education, unfortunately, is not playing the role that we were expecting in discouraging this phenomenon. So thank you. So I was trying to make my presentation as short as possible to be within the 10 minutes. But you are very welcome to read our paper, which you can find a copy of it on the ERF website. And any comments would be welcomed. We will be happy to answer any of your comments. Thank you.
Thank you, Ms. Ba. I think before we discuss your paper, we're gonna listen to the second presentation on using similar methodology, the high rates of C-section and its consequences for the timing of birth by Ms. Hanifa Bilvar. I think she's going to present. Ms. Bilvar is finishing her PhD at Queen's Mary University of London. And her co-author is Kausar Yousufi from the University of Tehran. The floor is yours, Dr. Hanifa.
Thank you, Marwa, and thank you everyone for attending this seminar. So today it's my pleasure to present this paper, which is a joint work with Kausar from University of Tehran. So the title is C-section and the timing of birth, evidence from a major healthcare reform in Iran. So first I want to start with the importance of C-section rates and why do we care about this rate. So basically, cesarean is a life-saving procedure if it is medically indicated for both the mother and the infant. But it has some risks, first of all, because it's a surgery and all surgeries have some risks for the patient. And because there are basically two types of C-section. One is elective or planned prior to the start of the process of labor, and the other is emergency. And the elective cesarean is a way of birth timing manipulation, which also has some risks for the baby. And despite all those risks, cesarean is preferred by doctors because basically cesarean is a certain and highly reimbursed procedure for them. And so many doctors induce the demand for C-section. However, there is a notion of optimal rate of C-section based on WHO statement on C-section. The optimal rate is something between 10 to 15%. And the statement also claims that there are few information about the consequence of very high C-section rates above the 30%. And this is one of the motivations of this paper, because in 2014, the C-section rate in Iran was 55%, more than 3 times the optimal rate. And this motivated the government to start a healthcare program to basically reduce this rate. So very quick overview of the program in Iran. So the program started in public hospitals. And as I said, it started in May 2014. It tried to basically change both the demand and supply for C-section. So from the demand side, after the program, the price for vaginal delivery reduced to 0. And from the supply side, so as you can see, before the start of the program, I call it T0 here. The doctors received 15 units for performing vaginal delivery based on the relative value units of procedures in Iran, and 17 units for cesarean, which made them earn 10% less for vaginal delivery. So in order to encourage them to basically substitute for vaginal delivery, they earned 30 bonus units after May 2014. So which resulted that they earned 2.5 times more for vaginal delivery rather than cesarean. In addition, a quota was set on a total C-section rate of a doctor. Basically the annual C-section rate of the doctor, the quota was 45%. And basically the doctors they wouldn't be reimbursed if they exceeded this rate. In 23rd September, this was not officially part of the reform, but the relative value unit for all procedures in public hospitals was revised, and in the new relative unit book, doctors were earning 50 units for vaginal delivery and 40 units for cesarean delivery. And because this basically satisfied the objective of the policymaker, they canceled the bonus payment for vaginal delivery. However, it reduced the relative earning in comparison to the 5th May. So basically we call this the second phase of the program. Also, it was not officially part of the program, but it affected the relative earning of doctors. So a brief, basically literature review. Our paper tries to contribute to the literature on physician-induced demand. So basically when physicians alter the patient preferences in line with their own interests. So basically because this program tried to change the financial incentives of doctors, we can basically discuss about the role of financial incentives of doctors in demand inducement. Also, there is a big literature on the causal effect of C-section on health outcomes of the newborns. And basically because we can benefit from this natural experiment to see whether we can identify any causal effect of C-section on health outcomes. And finally, because C-section is a form of birth timing manipulation, basically we can also tell something about the effect of manipulating the timing of birth on the outcomes. About the data that we have the data on the universe of all births from 2013 to 2015, which contains the information on infants' health outcomes, demographic characteristics of mothers, and delivery characteristics. We mainly focus on low-risk mothers, basically first birth young mothers. This is in line with the literature. So most papers, when they wanted to estimate the causal effect, they consider the least risky mothers. And we also mostly focus on public hospitals, which were the target of the program. Also, we basically provide some evidence for non-public sector as well. So first of all, the effect of the program and the C-section rate. So in this graph, you can see the change in the C-section rate relative to 1 month before the start of the program. So this is the change in the monthly rate. So the black dot shows the change in public hospitals, the red dot shows the change in non-public sector. So basically before the start of the program, these two are somehow changing the same, but immediately after the first phase of the program, you can see a sharp drop in the C-section rate in public hospitals, and just after 6 months, the C-section rate reduced by around 15 percentage points in public hospitals. But in non-public sector, you can see that the change is very small after the first phase, but in the second phase, they also reduced by something like 7 percentage points, because the second phase of the program also affected the non-public sector as well. About the change on health outcomes, so basically we cannot identify any effect in terms of Apgar score, mortality rate, and hospitalization rate. Also, basically the magnitude of change in the C-section rate was very big in our data. We find a small change in the birth weight. And finally, because our program has many aspects, and we want to discuss a little about the incentives of different groups. So we basically here we divide doctors based on their pre-reform C-section rate, and we call high-rate doctors those who perform C-section above the quota before the program, and low-rate doctors those who perform below the quota. And as you can see, high-rate doctors responded sharply after the first phase, and they reduced their C-section rate to below the quota, and the quota was 45%, the horizontal line. And basically, in order to dig more into the supply side contribution to the changes in the program, here we estimate the effect of YIJ. is the outcome variable for infant I in hospital J in year Y. DR IJ0 is a dummy variable, which is 1 for high-rate doctors and 0 for low-rate doctors. And T1 and T2 are the 2 phases of the program. So basically the interaction terms here, beta 3 and beta 5, they wanna basically capture the differential effect of the quota. And basically we wanna disentangle the different aspects of the program by this specification. So here we basically estimate the probability of receiving a C-section. We estimate the previous model, and instead of YIJY, we use a dummy variable if an infant received a C-section or not. So as you can see, basically in the first column, so at the baseline, those who those who were born by high-rate doctors, they had a 13 percentage point higher chance to receive a C-section. But after the program, the chance of receiving a C-section significantly reduced, and especially among high-rate doctors. And the changes are smaller in the second phase. Basically, all outcomes are manifested when we limit the sample to first birth sample. And basically, those are the main compliers with the program. And as I mentioned before, the birth weight didn't change much. The birth weight is a mechanical consequence of gestational length. And as you can see, basically the gestation length was smaller for those who were born by high-rate doctors prior program, but the gestation length significantly increased, and as a result, the birth weight also increased. And finally, to conclude, I want to say that so the program was successful in reducing the C-section rate in public hospitals, and it was mainly driven by first birth mothers. We tried to basically identify the effect of the quota, and the quota was had a major role in the success of the program. And a rough calculation shows that basically the program substituted around 45,500 cesareans with vaginal delivery in each year, which basically saved $10 million for mothers and insurance companies in the short run. Also, the cost of the program for the government was $71 million in the first year. So the program was not close to cost effective. Thank you so much.
Thank you very much, Hanifa. So we had two very interesting papers, both using natural experiments, causal effect for important outcomes of policy relevance. Let me briefly go over both papers. I apologize, I don't have PowerPoint slides for you. So for the first paper, just to restate what it did, basically examine the impact of policy change in education, reducing compulsory education from 8 to 9 years on 3 outcomes related to FGM, practice and attitudes. They use data from 2008 DHS to capture cohorts of women exposed to the policy change in 1988 and fuzzy regression discontinuity model. The findings were mixed. They found no effect on practice, but clear impact on attitudes. So I think this is, of course, an important paper, testing causal relationship instead of the usual cross-sectional model used to uncover association. And it's an important contribution to guide policy regarding elimination of FGM. FGM is an important issue worldwide. It's now part of the Sustainable Development Goals indicators. So it is quite of relevance. I have very minor comments, I should say. My first concern is that we're really talking about 1 year of schooling change, which would be, I think, too small to deduct an impact on FGM or related issue. And I think this could be the reason for the lack of impact on the practice. It's not really discussed much. It's just taken as change of compulsory scoring from 8 to 9 years is an important policy change. I think this needs somehow either you change, the title needs to be changed to reflect this, because right now it doesn't really say much about this change of schooling. My second point is a general point, which is we all know that FGM is highly prevalent in Egypt. As Misbah said, it's the highest in the world in terms of prevalence. It's still the majority of women, at least from the 2014-15 DHS, support the practice of FGM. It's very common among the highly educated and also among the high income group. which basically, I think some discussion of this, either in the discussion or the introduction, is warranted. It's basically a cultural practice, and that's why perhaps it's resistance to change in policy. My third and final point is that there is some repetition in the introduction and the literature review. They're very minor, but I think they should be taken care of. This is a very interesting paper. I enjoyed reading it. And I didn't really have major issue with the findings, the method, etc. For the second C-section paper, I think it's incredible that you had access to all of these data for the national level. So the paper examines the impact of the reform on C-section deliveries, targeting medical doctor and associated health outcomes of infants in Iran. It's a direct test of the physician-induced demand hypothesis, as Hanifa said. Basically, the hypothesis says that doctors perform C-section, especially in the private sector, to make money, to their self-interest, or for convenience. And they were able to test both of them. They had access to 2 years of administrative data for all births in Iran. I think this is an important paper. The C-section rate in Iran is one of the highest in the world. So it's a policy relevance. It's an evaluation of a nationwide intervention in C-section, which is quite rare. Different aspects of the intervention were tested, particularly the financial and convenience part of the doctor's demand hypothesis. The gain in birth weight was significant, about reduction, 5% gain in birth weight as a result of the intervention. I have very few comments. My first comment is that it wasn't clear to me actually what methods did you use to test the intervention. Somehow you need to spell it out and then justifying why we use this method in a bit more detail rather than another method. My second point is that the health effect on gestational age and birth weight is essentially a byproduct of the reduction in C-section. All other outcomes were not significantly different. So in a way, you're really just testing the reduction in C-section. My third, so some discussion of this perhaps is warranted. So the purpose of the intervention, as you stated in the paper, was in fact to increase fertility in Iran. But this issue was not really discussed in the conclusion and discussion section as to future research, perhaps, potential long-term impact of this intervention on fertility in Iran. So I was looking to see something, although it's not the focus of the paper. My fourth and final point is that the paper is really careful in describing the choices made in sample selection, other technical issues, and some limitations. Perhaps the main limitations of the study should be pulled out from the body of the text into the conclusion and discussion section. These are very minor comments. I really enjoyed reading your paper, and I think it's relevant and important. Thank you both for very exciting interventions. I give the chance to the authors to respond to rather minor comments that I had before we open it up for discussion. So Misbah, if you have any
Thank you, Marwan. So I totally agree with you that the results, the minor role that that education is playing in discouraging this practice could be in part derived by the fact that that policy reform is only including 1 year, so it's not a big change in the quantity of schooling that the students have taken, and this may mask the effect of schooling and may be responsible for the lack of effect that we found. We totally agree also that the practice, this FGM practice, may be derived by more other important cultural and traditional factors that we got that comment in two of the reviewers reported. So that paper we have revised and resubmit in one of the journals currently, and we got that same comment that we have to elaborate more on the context of that practice in the Egyptian society, on what drives that health risk behavior, and we also agree with you that the literature maybe has to be more focused, and by removing any redundant paragraphs or so. So we will definitely take your comments along with other comments that we are currently having. So actually we are having a very busy summer this year to take care of the comments that we are getting on that paper, and we will definitely take that into account.
Thank you, Misbah. I actually have written these points. I will, if you haven't received them, I will send them. Sorry, I didn't have prepared PowerPoint slides, but
actually,
it's an important paper, I think, and I wish you luck in getting it published. I think it's an important issue in Egypt and the region, actually.
Thank you. So actually, the session is recorded, so we are gonna watch. Wow. Okay. We are going to watch the session again. That's why I'm not taking any notes, because thanks to ERF, they are recording the session so that we can go back and watch it again and maybe write the comments later. So thank you.
Thank you, Misbah. We'll move to Hanifa. Would you like to address some of the comments?
Yeah, thank you, Marwa, for very good comments. So about the first comment here, maybe we should be more precise about the method. For example, we are using this event study and what are the assumptions, etc. So we definitely should include that in the introduction of the method. So about the effect of C-section on the health outcomes, and as you said, so basically birth weight is a byproduct of the C-section, and basically we are the only thing that we captured is that the C-section rate reduced, so gestation length reduced, so birth weight increased. Gestation length increased and birth weight increased. Yeah, actually, basically the focus of the literature on the effect of causal effect of C-section on health outcomes is mostly on long-term health effects, because most of them find significant negative effect in the long run, but the results of the effect on the immediate health outcomes are very mixed. For example, one paper finds significant effect on APGAR score, the other doesn't find anything on APGAR score and finds effect on hospitalization rate after birth. But all those papers they used, one of them used the data from California, the other used the data from Spain. All those papers used like diff-in-diff method or IVS strategies, and they were capturing a very small change in the C-section rate, and they could see all those results. For example, a change of 1 or 2% C-section rate, they could capture some effect. But in here also we had a very sizable change, a change of 15 percentage points. We couldn't find any effect on immediate health outcomes. And so maybe we should mention that basically, as I said, these are the mechanical outcomes that we are capturing, not basically we don't estimate any causal effect on health. So in terms of increasing fertility, yeah, actually we received this comment a lot, so maybe we should mention this in the conclusion that at this moment we cannot provide any evidence on fertility rates, because like most of these women that we studied them are still in their fertile age, and yeah, studying fertility is a more long-term outcome, but yeah, we should certainly mention that and what we expect, basically depending on the result of this paper, what do we expect to see in the long run in the fertility rates. And yeah, I think, so I think I forgot your fourth point.
It's a minor point, is that, you know, in the body of the text, you actually mentioned several limitations. Somehow, it depends which journal you're sending this to, but we like to see the limitations of the paper stated and discussed in the conclusion discussion section. I think they are scattered throughout the paper. But I would have liked to see them actually more visible at the end. Like it's an important paper. I really enjoyed reading it. I think it's relevant, and it's very rare to have access to such registration data to test policy and such intervention, the impact of such intervention. So that's it. That's the point, Khalifa. It's
yeah. So maybe we should include many things in the conclusion that we haven't done so far. Yeah, thank you so much.
Thank you, Hanifa, and thank you, everyone. I think the floor is open for comments, questions, remarks about the two papers presented from Egypt and Iran. Any hands raised? I don't see. Yeah,
yes, I'd like to make quick comments. First, for Hanifa, and also both papers I really enjoyed reading. Thank you very much for the work. For Hanifa, I have two quick questions, suggestions, sort of. So I think you have knowledge about the doctors performing the delivery, right? So maybe if you can add doctor fixed effects to the regressions, then you can control for the changes in the supply side. So you approach it's like so it is happening both in the demand side and the supply side, because it is beneficial for doctors to do the not do the C-section now, and also it is beneficial for the demand side to just capture the demand side and account for the supply side change. Maybe you can add doctor fixed effects if you have that knowledge. And also second thing, do you have information about the changes in at-home deliveries, at-home baby deliveries? So it might be another social benefit of the program if since now the vaginal deliveries are free. It might be the case that for those who might have preferred at-home deliveries, this might provide now an incentive to go to a hospital and to have a professional delivery instead of home deliveries. So if you can provide evidence about this decrease in home deliveries, it might, as I said, give give us ideas about another social benefit, maybe unintended or maybe not considered at all benefit of the program, decreasing at-home deliveries. So we want to decrease C-section, but also we want to decrease at-home deliveries, and this program might help in that case too. So if you have data on that, it would be nice to see that. So yeah, thank you. Like Marwa said, it's a great data. So yeah, well done. Thank you. And for Mesbah, your paper, I also liked your paper a lot. So I had some technical comments on the RD design. Maybe I can send you those later, but I wasn't sure if you are controlling for any covariance in the RD regressions. I couldn't see that. So if not, I think you need to at least control for month of birth fixed effects, region fixed effect, and rural residents. And also, I'd like to see the standard validity checks for the RD design. You know, you need to show that at that discontinuity level, your covariance should be discontinuous. Just the control variables should be continuous, but the predetermined covariance must be balanced around the threshold. So I would like to see those graphs as well. So I think it would be helpful for you to argue that this RD design is valid in your case. So other than that, thank you as well. I liked your paper too.
Thank you so much. Thank you.
Thank you, Belgi.
Thank you.
Other comments, questions? I don't see any hands. So I want to thank you all. Very good presentations. And thanks for the questions raised. It was an exciting session. And I think that's it. Belgi, do you
And
have?
I want to thank you, Marwan, and thank Belgi for a job very well done and a rich discussion, and to thank the authors for a fantastic set of papers and issues put on the table. Really, really interesting. Much appreciated. And Huda will be in touch, as always, to actually follow up with you to make sure that the very valuable discussions are brought on board the paper in a revised version that you can share with us for us to publish in the ERF working paper series. So with this invitation and follow-up, I thank you on behalf of the ERF team, and hope to see you in more ERF sessions.
Yeah. Thank you, Shireen. Great organization. Thank you.
Thank you very much, Dr. Shireen.
Thank
you
you
very much.
Our salutation to Huda Azmi.
Yeah.
Absolutely. Taban.
Thank you, everyone, for all panelists, attendees, and Huda, Shireen. Thank you, ERF team. This was a great session. So hopefully we will meet in person next year.
Yes, I hope so. I hope so. Till then, please all stay safe.
Yes.
Stay safe. Bye.
Take care.
Bye.
Bye-bye.
Bye. Take care.
Bye.
See you, inshallah.
Bye-bye.
Bye.